Howdy everybody, welcome back. If you are surprised why we're back, I made a mistake. I thought we were breaking for that. We're actually breaking at 1 o'clock. So we got 3 more interviews. And up next, I've actually got Aaron Black, who is the Director of Informatics. And we'd like to welcome Aaron. It's great to have you here. We'd like to hear a little bit about what you guys do.
Yeah, so I'm the Director of Informatics. So our team is the infrastructure, data quality, acquisition, and access for an institute within the Inova health system. And we're based in Northern Virginia, about 15 minutes outside of Washington, D.C. Our institute started about 5 years ago, so you can almost consider us a little mini startup within a healthcare system.
Cool.
And in the past 5 years, we built some infrastructure support, really taking this genetics, genomics, and other types of biological data and transitioning that into actually helping our patients within the health system.
Very cool. Can you like give us some examples of, because that could mean 20 different things.
It could, and right now there is a lot of activity in this space, and I'll give you a couple of examples, maybe a smaller one and a larger one.
Sure.
One of the smaller ones is we are doing pharmacogenomic testing, which is how do you respond to drugs that you're given? Are you going to be a good responder, bad responder, or is it going to have no effect?
That is cool.
And what we do within Inova is if you come in and you, for example, we do a sequencing of all newborns at our Fairfax hospital. So if you come in and you opt in,
any newborn,
but your parents would have to consent, so it's not like we have to, you have to do it.
Quite a bit of uptake with that.
Yeah, it's very interesting who wants it and who doesn't, but we have a pretty good uptake. The mothers sign the consent and we sequence your baby in various parts of their genome that we know has an effect on how they'll do on certain medications. And that becomes part of your health record. So, when we talk about, our goals, it's really trying to move healthcare from more prediction as opposed to waiting until you get to the hospital to treat you. So there's a ways. Yeah, absolutely.
Roll the dice.
So the term precision medicine has various types of interpretations, but that's one way. We're treating you precisely the way that your genetics are telling us to treat you.
That is very, very cool. Yeah. And where does Tableau fit into what you guys are doing?
Well, Tableau actually fits in a lot of ways. So it's not just like one aspect that we were looking for, because we are data rich, meaning we have all types of data. So genomics, we have molecular data, so RNA sequencing, so that's basically, does the DNA actually manufacture anything that will be actually a protein? We do electronic health records, we do surveys, we have all types of data that are moving around. So our biggest thing was data management. How do you know where it all is? How do you know how big it is? A lot of times it's a cost to tow a bunch of data that you don't need. So what we've used Tableau initially for was just, what's the lay of the land? I came in 2 years after they started, and I'm actually more of an accountant by trade. I said, well, what is it? You have 2 petabytes of data, where is it?
Yeah.
And so we started to hook these things together, and Tableau was our way to really start to quantify and visualize data that really, Inova is one of the leaders in genomic medicine, because we started sequencing right after the Human Genome Project, and another one called the Cancer Genome Atlas, which is where I come from.
Gotcha.
Which are these
and
large
been out
scale.
For, 10, 15 years?
Yeah. So, but it's still expensive. I mean, even today, $1,000 a genome is still pretty expensive if you want to do 1,000, 10,000 people. That's millions, hundreds of millions of dollars to just get it, not even do anything with it. That's just to hold it. So again, Tableau has helped us figure out, okay, we've got it. How much is it costing us? We're a cloud, we use Amazon to store our data.
Yep.
So how much is that costing us when we move it from point A to point B? What are the costs? How long does it take? So measuring logs, measuring data sizes. So these things, like I said, we have 2 petabytes of data, and then we have clinical systems. So what is the measurements that we're tracking? What are we getting? How do we start to build cohorts of people who, so for example, we have a study that does a longitudinal study on babies. So we sequence them right at birth, and we're going to track them for 18 years. So now we have some of our first kids are now 5 years old. And now every time they come in the health system, we've consented them, and now we can track them. Are they, getting obese? Are they getting autism? Now we can start to build cohorts of people and look at how much is it environmental versus how much is it genetic? Because that's typically the question people have. It's like, it's not all genetics. What is the impact of anything? So we're getting a lot of studies and sub-studies on just building a massive cohort of data. But again, you can't just throw it all one place and hope it does something. You have to manage it. So that's where we've used Tableau quite a bit.
That is very cool. And are you guys finding a lot of cross-pollination with other folks doing this? Because I can imagine, it's a thing of scale, right? If you've got a sample of 1,000, it means one thing, but 100,000 means something else.
Yeah. So there's a lot of movements. So the reason we actually gravitate towards the cloud is because it's easier to share data. Now we have a business associates agreement with Amazon. We're very secure up there.
Yep.
So it took us a year just to get through legal to get it, but that's the reason we put it up there, because if someone from for example, we have one with Scripps, which is in California. They want normals. They're doing a study called the Welderly study, which is older people that are doing well.
Okay.
And so they have a bunch of people that are doing well. They said
Welderly study?
Welderly.
Yeah, welderly.
Welderly.
Got it. I love it.
So they combine two terms there. But we can become the control for that because we're across the country. We have older people, 80 plus, so they can start to see what are the variations that are making these people live longer. So we can start to share data more effectively because, like you're right, unless you sequence millions of people, sometimes the numbers don't make sense.
Right.
So how do we start to build these little cohorts easily? And again, Tableau is a great way to visualize our discovery process. So now you can actually search through and say, well, tell me people that are over 80 that don't have heart disease, that, right? And then you get to see it, you see all the data, you see how big it is, and then we can put in calculations that say, well, this is what it would cost you to download it, this is what it would cost you to compute against it, here's the size of machines that you would need. So it's really, again, I'm a move a business person, becomes almost a business that until you really see it, you have no idea how to quantify it.
Sure.
And again, Tableau has been great.
It's
Financially
gonna work
viable.
out.
Yeah, I mean, you get a lot of grants and contracts, but eventually we thought about it as, what's going to happen when the health system sequences everybody?
Yeah.
Right? What is that going to look like? Can we do it? I can tell you 1 million people is about 134 petabytes of data.
Wow.
And that's just the stuff that's kind of, I would call the intermediate. So if you go to a health system executive and say, I want 134 petabytes of storage, they're going to laugh at you.
It's got to be secured.
Right?
Yeah,
all the way through.
Times two, because you need a backup.
Yeah, and then what do you do with it? It means one, it's not bigger is not better. You have to have the quality, you have to have the processes in place so that when you want to do that, you can move.
Cool.
So that's really a lot of the stuff that we're doing right now.
So you guys are right now, because it sounds so interesting that the big data storage problem, having to store that much data.
Yeah.
You guys are going in and identifying certain parts of the sequence and saying these are more relevant, or we think these are, and like storing a much more massive subset of. Let's say it was 1 petabyte, and you could trim it down to what you think it is. How much? I'm just a geek. I love learning this stuff.
So think about it like this. It's a funnel.
Yep.
Right. So you get the data. So 2 petabytes. So we're also think about the concept of a data refinery. So you bring the data in. These are packages of data. It's not like one thing, right?
Yeah.
The sequences are quite variable. You get anywhere between 20 and 25 files. Okay. So we deposit those in Amazon. We process them, and we pick out what they call the variants.
Okay.
So you don't look at all 3 billion letters, and that's what it is. You pick a model. You pick. Basically, it's a generalized, non-disease individual, and you point it to that and say, what are your variations? So we're typically only varying 0.9%. So usually we're like 99, and there's different statistics here, but we're basically 99% the same, and we're only those little small things off. So a variant file is 4.5, 5 million rows.
Okay.
Right, and that's per person. So then you take that, and that's actually what we try to make as actionable as possible. That's the manufacturing. Then it gets
4.5 million per person.
Per person.
Oh my gosh.
So what we've been doing now, and we actually want to get back. I'm flying back this weekend. We have a Hadoop cluster that we're going to put all that variant data into. And so we've been working with people in Seattle and people in at Cloudera to build a model so that we can actually automate that pipeline. So when a sequence comes in, we're shuffling the cards. We're doing structural variation. We know it's a person, a human. We move it into Hadoop, and that's where we can put Tableau on the front end of that. And we've been working a lot on data partitioning schemes, ways that we can model that data so that it can be as fast as possible. Because right now, when you look at everything, it's very hard to target everything. Now, if you're doing pharmacogenomics, you can pick certain spots, and people have been good at that. But on the research side, you want to see things that haven't been seen before. So being able to target maybe a certain chromosome that's known to do something is very valuable. So that's what we're trying to do, is we're trying to build a manufacturing facility for genomics, but not just genomics. So there's all other types of metabolic data, proteomic data, and it's like it comes at you, and so we need the tools in order to do something with that. And again, we're in a need. I mean, healthcare is pretty risk averse, where they don't like to build things and because there's obviously patient care involved.
Sure.
So we've segregated ourselves off into Amazon, into a research area, so that we can actually iterate and find these things, and this is the reason why we come to these conferences, is to find other people, not just in healthcare, but in oil and gas and in finance, who are already ahead. Now they're doing maybe different types of files, but generally they're at the I think the sizes that we're looking to get into, and so we don't want to recreate the wheel. We want to find other people that are doing really cool stuff.
Very, very cool. And that's the beautiful thing about joining this community at this point with the 10-year history, is you can come in and a lot of wheels have been built already. You just got to find out who did it. And then the one thing about Tableau, do you find that they're pretty open about that? It's easy to connect with other folks?
Yeah, absolutely. And I think when I came here, one of the things I noticed about the conference, and I've been to conferences all over the country, was one in England last week, is this is a very engaged community.
Yeah.
There's a lot of work, and you just go to
Folks
Twitter.
just show up and spend half the day in the
And they
hotel.
embrace the
right.
data culture.
Yeah,
right?
yeah.
So, we look at like who we want to partner with. We want people that are very excited about what they're doing and what's coming next. So, seeing all kinds of data tools that honestly 5 years ago weren't here. When you think of the whole stack from ingestion to quality control to visualization, none of this stuff was there. So, and there's tons of technology everywhere. So you really have to find, 30, 60% of my job, because it varies, is just technical evaluation. Like, what is the right tool? There's
Especially on top of Amazon, right? Because it's moving so quick.
Yeah.
And if you're like in the two areas where things probably change faster than either space.
yeah, it's
lucky guys.
exciting but scary, right?
Totally.
And the talent is thin because you want to try to get people that know the cutting edge. And so by the time you found something, you're on to the next thing. So
Right.
finding that right kind of niche for us has been a challenge. But again, coming to these conferences, we see the explosion of people very excited.
Awesome. And speaking about the next thing, were you able to catch the keynote yesterday with all the new features and
Oh yeah, very
all that stuff?
excited.
What do you guys
Maestro, the Maestro one, which is the self-service ETL,
Yep.
could be a game changer for us. So my team is pretty small, so we're about 15 of us, and so if
Stretched,
you
yeah.
want to do ETL, you have to come to us. Like even if you want to look up, our users aren't super sophisticated. I mean, the
gatekeeper,
clinicians,
right, and that slows
nurses,
everything down, yeah.
right? If we can find a way to educate them and put that in their own hands. I think the speed of discovery for us is key, and discovery meaning is it a lead that we should take or not. So sometimes they ask a question, and within minutes they could say, well, that's not a good lead. I need to move on to my next thing.
Yeah.
Well, right now they might spend 6-8 weeks trying to figure that out, and then fail. So the faster we can get them to that point, the better. And these self-service tools, it's almost like a democratization of data that really hasn't been at their fingertips ever, like any other time. When you look at genomics, I mean, they've never seen data this scale ever in the world. And to be in a point in time where this is actually occurring is actually extremely exciting.
Absolutely. Yeah, totally. And you had just mentioned ask questions, right? Being able to ask questions, the natural language processing that's actually coming a lot.
That was
They
really
will
cool
literally
too.
Be able to ask questions.
Well, I
of the
think
data.
one of the things about healthcare is it's so diverse in the way it calls things. So you could be at a hospital system and you have a term, and it's different in another hospital. And so a lot of the management of that data is the blending and the semantic kind of interoperability of that.
Sure.
We've actually done a lot of work with that with other tools, but by the time it gets into Tableau, we've hopefully streamlined a lot of that. But sometimes they don't know what we call it, so that natural language processing can help quite a bit, where they're kind of drowning in a sea of terms, and if they can quickly just say, hey, I want to search for something like this, I think, again, back to the speed, I think that will help us out tremendously.
Very, very cool. And on the infant program that you're doing, I'm sorry, which hospital?
So it's Inova Fairfax Hospital.
Inova Fairfax Hospital. Have you guys been able to give parents like actual recommendations, or are you still
Yes.
in collection phase?
No,
And
no.
What are some of the cool things
Well,
you caught?
So we found 10 to 20%, and I could be wrong on the necessary percentage, but we found in that population that we're actually finding in actual things. So a kid that doesn't respond well to codeine. Now, when you're a baby, typically you're not getting the drugs right away, right? Hopefully you're a healthy baby moving through.
There's complications,
But as we move forward, we actually return those results back to the record. Right now, it's a big report.
Okay.
And what we're working on now with the Epic, which is our EMR system, is putting those discrete results within the health record so that as the babies come back in, you get an actionable alert that says, hey, you're about to prescribe this particular drug. Are you sure you want to do it? And here's the reasons why. Go to this report and you can see the detail. Now, one of the challenges there is most hospitals or most doctors don't have the time to dig through a report. So that's why we call it clinical decision support, is very key for this.
Sure.
And as we're going to spend a lot of money in this data, we want to put it in the best place for those clinicians to make the right choice.
Absolutely, and that's gonna drop down. Like everybody's, healthcare has gone up quite a bit. And
Well, I think it's, again, back to the prediction and the prevention. I mean, we want to be, instead of having an adverse reaction to a drug, if you could stop it. So you spend a couple $100 immediately, but it can save you thousands of dollars all throughout your life.
absolutely on liability insurance. And the
I think there's
whole thing,
so let me give you a story, and we only got a minute left.
Yep.
I actually had my sequence done.
Okay.
And my father, so I had my sequence done about 2 or 3 months ago, and got the report back, and it said I would not respond to Plavix, which is a blood thinner. So
Okay.
helps you when you have conditions with heart attacks.
Gotcha.
Well, very, very soon after that, my dad actually had an issue where he had 99% blockage in one of his arteries.
I see.
He was going to have a heart attack almost at any time. And so when I got those results, I immediately, at 50-50 stance, he's got the same thing I do,
Sure.
and he's not on Plavix.
Wow.
So it's impacting me already, and I think that's really the model that we're trying to do there is utilize this data to really protect and help the people that we love. I mean, at the end of the day, that's why we put up the fight. That's why probably I have no hair. Is that day to day, we struggle through these types of things, and we want
See
them.
the passion in your eyes.
Yeah. Those types of things, and that's what gets our team motivated, and that's where we hope to go.
Very, very cool. So how long before this is available to everybody?
I think that's where the economics comes in.
Okay.
Right? Because at the end of the day, this still costs money.
Sure.
So they want to improve the effectiveness, and that's another thing we want to do with Tableau. And I was talking to some of the gentlemen last night about creating a pilot where we can start to look at the effectiveness of this. Because if we can get reimbursed for it, because right now Inova pays for it.
I see.
Out of their pocket, because they really believe this is the future.
I see.
But going forward, as we expand those pharmacogenomics to other drugs, as we do cancer, as we do heart and cardiovascular neuroscience, I mean, think of all the applications that are genetically oriented.
Sure.
We want to open this up and prove that, we should get reimbursed for this because we are saving you money. We're keeping people healthier, and hopefully it's an attraction for people to come to Inova.
Yeah. It's ROI, you're making people's lives better.
Yeah, I mean, there's a
win-win.
business behind it, unfortunately, but that's what we're trying to prove.
Sure. And I want to leave a couple seconds. Your talk, have you already given it or it's coming up?
It's tomorrow at noon at the Hilton,
Okay, cool.
the life sciences track.
Tomorrow noon at Hilton, and it's called the Inova Translation Medicine, Enabling Precision Medicine for Personalized Healthcare Delivery.
And the key is enabling, yes.
Cool. Fantastic. Aaron Black, thanks so much for joining us.
Thank you very much.
Great conversation. Enjoyed talking to you, and love the passion, man.
All right, I appreciate it.
Take care.
Thank you.
Thanks, everybody. We'll be right back.